Welcome to Eye Contact, a video news program on issues and controversies in ophthalmology sponsored by Eurotimes. I'm Sean Henahan. At this year's meeting, we're seeing a lot of interest in new and evolving techniques for corneal transplantation. Today we will be talking about some of the debates and controversies going on in the field with Dr. José Güell, Barcelona, Spain. Dr. Güell is the immediate past president of EU Cornea. Welcome, Dr. Güell.
Thank you very much.
You'll be speaking at a joint session of the EU Cornea and the ESCRS on modern corneal transplantation. Let's start with keratoconus. It's probably still the leading indication for keratoplasty. What role does PK play versus DALK and related procedures?
Possibly in a significant number of countries, still keratoconus is the leading cause for transplantation, although in a significant number of them is switching to regraft as the main cause of a transplantation. And at the same time, I hope that we will see a trend in the keratoconus area to a lower number of cases of transplantation, because with the new techniques that we have, specifically cross-link, possibly most keratoconus will not reach a deformation level to need a transplantation. Anyway, going directly to your question, between full thickness transplant and anterior deep lamellar surgery, there is no doubt that for most corneal surgeons worldwide, except when there is a particular contraindication such as previous perforation, the best approach is deep lamellar, because we do not transplant the endothelial layer, which, as you know, is the main cause of possible rejection episodes after the surgery. So this is the classical example of a situation where you need to do a transplantation because the cornea is not working properly well from an optical point of view, but where the posterior layers are perfectly healthy. So there is no reason not to consider a lamellar surgery in front of a full thickness transplantation.
And that's providing good visual outcomes?
Yes, there was a strong debate for a number of years, and in fact, because, as you can imagine, those results published in long control series, when they appear on the publications arena, they have some years. This is the resume of the experience of 10-15 years previous surgeries, and that's why the debate between full thickness and anterior lamellar was quite hot. With the newest series, there is no doubt that deep anterior lamellar, especially if you leave less than 70-80 microns on the posterior stroma, so not necessarily if you reach this symmetric level where the optical results and visual results are exactly the same as with full thickness, but inclusive in those cases where you leave some residual stroma, as long as it is thinner than about 80 microns, visual results are perfectly as good as well for thickness.
Now, so much is happening in the field of endothelial keratoplasty. Sometimes it seems there's a debate between DSAEK and DMEK. What are the potential advantages of each? What's going on in that area?
Well, again, because it's, as you mentioned, it is a so active field, things have been happening too quickly. And of course, when the MEK reached the real surgical arena, not the potential capacity, but the real clinical data, visual results were significantly better for the MEK, for the standards of the SAEK at that time. But of course, the SAEK at that time was also in its own improving line. And what we know today is that the thinnest the lenticle for the SAEK the better the visual and refractive outcomes. And so today, the most advanced DSAEK surgeons used to have similar results as the ones that we, as myself, are working with the DMEK. So I do not think that visual acuity today, in good hands for both surgeries, creates a significant difference. I think that optical quality will always be better for the DMEK, because obviously you are transplanting exactly the same as you are extracting. So the optical structure of the cornea keeps exactly the same after the surgery, which cannot be the case after the DSAEK.
DMEK is often said to be such a complicated surgery to learn, the long learning curve, so many interesting problems like unrolling the taco and so on. Has the supportive technology for DMEK improved? Is that getting better? Is it getting to be maybe a little easier to do?
Yeah. In the case of the DMEK, compared with the DSAEK, where we are depending on newer technology, new instruments to improve particularly the thickness of our lenticles and the uniformity of our lenticles. In the DMEK, it has not, from my point of view, it has not been so much the technical improvements, but the surgical improvements. So I think that as soon as more and more surgeons, especially young surgeons, became the DMEK surgeons, together with the old ones, I am in this last back. I think that those improvements has amplified a significant advance in the speed of put the lenticle in place, and the diminishing significantly what in the beginning was a limitation, that is the rebubbling rate. So today, I would say that for most of the experienced DMEK surgeons, positioning the membrane in a regular case takes not more than 5 to 6 minutes, and rebubbling rates are below 1-2% in most of the newest series. So I think it has been much more because of a surgical training learning curve than because of the use of new materials or new instruments.
It would be hard to do DMEK without OCT, and OCT continues to evolve as well. How have the evolutions in OCT helped with DMEK?
I think it is a good question, because industry used to, and I do not want to generalize, but industry wants to give importance to some of their tools before we have said that they are important for us, and then it creates a kind of confusion. No? I really think that the OCT helps, especially in those cases where the view through the microscope is not good enough for you to distinguish not only the positioning, but if the roll is in a reverse position, if it is well positioned once you has introduced the air. So I think that the OCT is a extremely useful tool in a group of difficult cases where visualization might have some limitations. In some others, has gives to you an additional information which you already have with either direct view through the microscope or using the slit lamp inside the microscope.
Now let's look far ahead. It seems there will never be enough corneas to go around for transplantation. What about corneal regeneration?
Well, this is again a good question. It's an old story that is definitely improving. I think that today, well, you know that basically we can consider the cornea a 3 layers structure with a central, the thicker stroma layer, and then 2 cellular layers. The exterior is epithelium, the anterior is the endothelium. So there are today enough clinical data to know that we may have substitutes for the stroma that works extremely well. we have enough clinical information about being able to resurface this artificial stroma with cultured epithelial cells. So still today the limiting factor is substituting or creating artificial endothelial cells. There are several groups worldwide, there are some in Japan and some others in other parts of the world working on that. And so I think that to have this 3 conceptually layered structure in the near future will be easy for most of us.
Fantastic. We look forward to that. Thank you so much.
No, a pleasure.
Thank you for joining us. For more information on this and related topics, please visit us at eurotimes.org.